Hello friends, I am Dr. Himanshu Shekhar. Today we will study about the development of diaphragm and congenital diaphragmatic hernia. What is diaphragm? We all know that diaphragm is a musculo-tendinous partition that separates abdominal cavity and thoracic cavity. So the development of diaphragm. Diaphragm develops from four parts. First is septum transversum. Second is dorsal mesentery of esophagus. Third is muscular ingrowth from lateral body wall. And fourth, pleuroperitoneal membrane. So this is the oval shaped diaphragm. Here is the vertebra. First is the septum transversum. This I am showing by this yellow. This is the anterior component. This septum transversum is having three parts, or three things developed from septum transversum. First is the opening for IVC, that is on the right side of diaphragm. Second is the opening for esophagus. Here is the opening for esophagus. Third is the central tendon. Third is central now the second part is dorsal mesentery of esophagus. So this is the dorsal mesentery of esophagus, and aorta lies here. This is aorta. Third are muscular ingrowths from lateral body wall. So these are the muscular ingrowths from lateral body wall. And fourth is the pleuroperitoneal membrane. So this portion here is the pleuroperitoneal membrane. So these are the four components from which diaphragm develops. So now, what is the significance? So this is the anatomy of diaphragm. This is abdominal view. So this is the right side, this is left side. On right side we can see this is the opening for inferior vena cava lying in the central tendon. This is esophagus through esophageal hiatus. This is the opening for aorta. And what about the nerves? These are the phrenic nerves. So we know there are three openings in diaphragm. First is opening for IVC, second is opening for esophagus, and third opening is for aorta. So to remember it, these are the levels. So IVC is at T8 level, esophagus is at T10 level, and aorta is at T12 level. So the mnemonic for this is I8 10 eggs at 12 a.m. So I for IVC, this is T8, 10 eggs, that is T10 level, is for esophagus, and aorta at T12, that is T12 A for aorta. Now during development, diaphragm moves from C2 to its adult level. So it carries the fibers of C3, C4 and C5 with its nerve supply, that is phrenic nerve. That's why phrenic nerve has fibers of C3, C4 and C5. Now congenital diaphragmatic hernia, that is CDH. So any opening in diaphragm besides its normal three openings causes congenital diaphragmatic hernia. So what are the types? What is the pathophysiology? Or pathophysiology. We all know that during the development of midgut, the abdominal cavity is having very less volume and midgut growth is very fast. So during fourth week midgut eviscerates and lies outside the abdominal cavity. by 10th week it returns to abdominal cavity. So by 10th week diaphragm development should complete. So suppose there is incomplete development from septum transversum, that will cause Morgagni hernia. If the pleuroperitoneal membrane development is incomplete, that will cause Bogdalic hernia. So if at 10th week diaphragm is not developed, so return of bowel cavity, return of bowel causes increased abdominal pressure, and if diaphragmatic development is impaired, then bowel will go into thoracic cavity. We know that during midgut development, midgut undergoes rotation. So in congenital diaphragmatic hernia, non-rotation या malrotation of bowel is also present. Pulmonary vascular resistance will be increased, and there will be associated heart defects, that is patent foramen ovale, patent ductus arteriosus, and amniocentesis. Third thing which we will see in USG is lung to head ratio. This is also called as LHR. So this is the width of lung upon width of head. So if it's less than 1, that means the diameter of lung field is less than that of head, then it is poor prognostic factor, poor prognosis. and if it's more than 1.4, that shows there is adequate lung growth, and this is good prognosis. Last, we will see, we can do fetal MRI. So this MRI is done to see other associated congenital anomalies and liver position postnatal diagnosis. So first, clinical presentation. So the clinical presentation, this will depend on the severity. Of defect. The baby can have respiratory distress, persistent fetal circulation will be there. So the baby can have dyspnea, cyanosis, so on examination, baby will be having a scaphoid abdomen. Decreased breath sound on ipsilateral lung field. Chest will be asymmetrical chest. Mediastinal shift, sternal retraction, this can all be present. So what will be the diagnostic tests we will do? So diagnostic tests. So first will be chest X-ray, and in chest X-ray we will see the bowel gas shadow in thoracic cavity. If we are trying to put nasogastric tube, then nasogastric tube will be in thorax, because the stomach is inside the thoracic cavity. Chest opacification will be present in lower transthoracic echo. Transthoracic echo we will be doing to see the lung as well as heart, and to rule out other associated anomalies. MRI can also be done mostly for right-sided defect. right-sided defect to rule out hepatopulmonary fusion, in which the lungs and liver are fused. So these will be the diagnostic tests. So what will be the treatment? So first thing is that this is a physiological emergency, not a surgical emergency. So first we will support the patient's physiology, that is the baby's physiology, and we will give him some form of nutrition to build the baby. So first we will do the endotracheal intubation. Bag and mask ventilation is contraindicated. Why? Because if you do bag and mask ventilation, air will go into stomach, because it is the pathway of least resistance, and further dilatation of stomach, and it will lead to pulmonary compromise, as the lung don't have place to expand. So first we will do the endotracheal intubation. Nasogastric tube for decompression. And we can also use sedatives so that baby don't make efforts, and it will decrease the lung injury. So to decrease the efforts of baby and protect lung, we can also use ventilatory adjuncts. What are these ventilatory adjuncts? These are high frequency oscillatory ventilation. High frequency oscillatory ventilation and nitric oxide, which dilates the pulmonary vasculature and decreases persistent fetal circulation. What will be the contraindications of extracorporeal membrane oxygenation? Prematurity and irreversible heart damage, in which the baby is not salvageable. These will be the contraindications of ECMO, non-viable congenital malformation. Now the surgical repair. So surgical repair, these will be delayed repair after the baby is stabilized. So after stabilization, so what will be the timing? So timing will be whenever the baby is stable, so after 48 hours. After 48 hours of stabilization. After 48 hours of stabilization. So there will be two techniques. First, open method. In which the after reduction of contents, the defect can be closed, either primary closure with mesh, with non-absorbable suture and mesh, or in case of loss of domain, that is the defect is very big and most of the contents in thoracic cavity leave the abdomen open and delayed repair. Second method will be thoracoscopic. Principle will be same. Principles same, only the approach is different. Now prenatal treatment. How? Suppose the condition was diagnosed antenatally on ultrasound and other investigations. So what can we do to so we can do a fetoscopic surgery. That is called fetoscopic tracheal occlusion. In this we will occlude the trachea by clips or balloons. So this will increase the pressure inside lung and lung can grow. And we remove the clips. Or puncture balloon under USG guidance at 34th week of pregnancy. The last topic which was left is types of congenital diaphragmatic hernia. First is Morgagni hernia. First is Morgagni hernia or retroesternal hernia or Larry's hernia due to defect in septum transversum, most commonly on right side, needs surgery even asymptomatic because high chances of sigmoid colon evisceration and obstruction. And the second one is Bogdelic hernia. Bogdelic hernia, this is commonly on left side, posterolateral. This is because of malformation of pleuroperitoneal membrane formation. So if you like this video, please like and comment, and if you want me to make more videos like this, kindly tell it in comment and I will make the videos. Thank you.